So it's very important to talk about nutrition, diet, because it is a backbone of any therapy, rather any therapy related to diabetes, obesity, atherosclerotic cardiovascular disease, right from primordial prevention to primary prevention to secondary prevention to tertiary prevention. Throughout the course of journey of non-communicable disease, diet and nutrition is an integral part of management. But it is the toughest question, tough and very tough question, and complex answer is always coming. So if each and one of us given one task to tell diet of a person or a patient of diabetes, we are going to prescribe in a very different way. Each one of have their own issues, own approach towards nutrition. And most of these things are regarding pattern of diet, what they are going to consume, how much they are going to consume, and what percentage of macro and micronutrients should be there, at what time they should consume, what should be the frequency. So there are always gray zones, and we are always worried whether we are on right track or wrong track. So it's embracing complexity of diet and nutrition in patients with obesity and diabetes. I'm going to talk about that. So we always hope to answer these questions. Those who seek our care, what can I eat? It's a really toughest job to be done. And what is more worrisome for all of us, that the answer comes from a person who is not properly trained. And what this person gives, a handout of a paper to that person, that these are the things not to be taken, these are the things to be taken. So the simple dietary advice is a piece of paper which patient turns out or throws out once patient goes out of the clinic. And still the things are that we are very much clear that one size doesn't fit all. So nutrition and diet, this is one of the very important aspect, and clearly indicating that this is individualized approach or patient-centric approach. Because if you see, our diet changes, our language changes, our socioeconomic status changes, our religions and beliefs change, and our culinary skills and practices, they change every 100 kilometer. What to talk about the state or zone, every 100 kilometer you travel and everything just changes. And what patient goes for? Patient goes for Googleization, and he goes for internet. And if you believe me, on internet, around 2 lakh diet charts and dietary advices are there. And some of these charts are for curing diabetes. Some of these charts are for curing obesity, and that is permanently. But problem with all of us is that in nutrition research, the large and rigorous clinical trials are lacking. And most of these studies are either short-term studies or they are poorly powered studies. And the controlling intervention arm is very difficult to be there, and they are very costly studies also. And can we, that study which comes to us, can we implement the things for a long-term purpose? It is only the studies for 6 month or 1 year trial, or at the most 2 year trial. But can we implement the thing for the long term? So it's a big question for all of us. So it's a too complicated matter. Nutrition recommendations change over time, just like other fields of medicine. And we always say it is easier to change a man's religion than to change his diet. If you ask me to eat at this time, at this type of food, always, every day of the week, whole of the month, whole of the year, I think this is just impossible. And sometimes things change even with year to year guidelines are changing. Earlier, we used to say no to saturated fats, absolutely no to saturated fat, absolutely no to carbs, refined carbs. So now the things are changing. The quality and quantity of nutrients matter. And it is not no to anything. Even patients of diabetes can have fruits also. Why not? They should enjoy everything. So it's very important to understand the complexity of dietary patterns and the advice we can give to our patients. So it's a greatly unmet need for all of us to have consensus guidelines, national on guidelines should be there, and there should be regional wise change, and it should be fully N1 type approach. And I call N1 type approach one patient, and we have the answer for that. That means patient centric individualized approach should be there, because evidence suggests that there is not an ideal percentage of calories from carb, protein, or fat that we used to teach ourselves. 55 or 60% should be from carbs, 20% should be from proteins, 30% or less that should be from fats. So that we used to mug up all these things and tell our patient accordingly. We prescribe the diet to our patient of obesity and diabetes. But these are the things which are gone over now. So the consensus recommendations are quantity and quality of macronutrients matter. They can enjoy the proper blend of nutrition, or all food which is calorie complete and nutrition complete also. So calorie restriction, nutrition complete should be there, and it should be individualized approach. And it is very difficult to put foods into perspective of macronutrients in the form of carb, in the form of fats, in the form of protein. If you ask any postgraduate or recently passed out a person, he will say this much amount of carbs to be given, this much amount of fats to be given, this much amount of proteins to be given. But if you see the plates in front of you, the patient is consuming the meal, the breakfast, blend of carbs, fats, and proteins. Lunch, blends of fats, carb, protein. Similarly, dinner. So it's never individualized macronutrient. So one thing is very important, that we should go away from that restricted thinking of macronutrient driven diet. So it's very difficult to put foods into precise category, whether you are only taking carbs until unless they are purely refined fast carbs. Purely taking ghee or butter or margarine, or you can say it's oil, that is fat. But most of the things which we consume has got blend of fats, have blends of protein, and also carbs. So people eat food, not macronutrients individually. Remember, this is the thing which should be changed from minds. So macronutrients, what do you notice? What happens after you eat a meal? This is one of the best perspective to ask patients about the individualized pattern of taking food. What happens after you eat a meal or a particular food for your glucose? That is the most important indicator or most important surrogate marker of having proper nutrients, proper macronutrients in the form of carbohydrates. And why carbs are important? Because they have got direct implication of release of insulin from beta cells of pancreas. And we are always worried about carbohydrates. Less about rules and formulas, more about trial and error. So this is one of the important principles. Important to develop individualized troubleshooting skills. That means before meal, this was my blood sugar. Consumption of the meal, after 2 hours, how much is my blood sugar? So it's a very important, valuable tool for looking for the increments of postprandial hyperglycemia by consuming some amount of that food. So that is the most valuable tool that will tell you how much the food or the type of carbohydrates, the quantity and quality of carbs is going to influence my blood sugar level. So this is the best tool, because each and every person will have different spike. Today morning, I was sitting in OPD and I asked the patient to take apple and papaya. He says apple is okay, but once I consume papaya of around even 50 gram or 100 gram, my blood sugar shoots up. So that is very clear. He has got different way of metabolizing that fruit. He spikes, he is not lying. He spikes the blood sugars with the papaya. Maybe he's consuming the mashed part, or maybe he's consuming the overripened part of papaya. So that may be one of the reasons, but he is very true to his values. So it has to be clearly insightful thinking about diets. What would you do to differently on the next time? So that is involving patient in dietary modification. Change the amount or change the ingredient. That takes care of the concept of glycemic index and glycemic load also. Ultimately, goal is to enjoy the food and meal, understanding how it impacts your glucose. So they can enjoy everything that is on this earth. They can enjoy the food, everything that is available on this planet Earth, but that should be having proper metabolic response to that type of patient. You can see the differences between Asian and Caucasian counterpart. This is YY paradox of Professor Yudnik and Professor Yagnik, having BMI of equal 22.3 and 22.3 each. But you can see the body fat differences. Yudnik having body fat of 9.3% and body fat of 21.2 with Professor Yagnik. And that clearly comes even from your childhood. That means a child who is born with the weight of 2.5 kg. Everyone is happy. You have given a birth of a child who is a baby is at 2.5 kg. So it's a normal birth weight for our own standard and very healthy birth weight. But if you go for the body fat percentage of that child of 2.5 kg, will be having at least 5 to 10 times higher body fat in comparison to 3.5 gram for 3.5 kg of Caucasian baby of the same age. So right from our womb, the maternal womb, we develop that type of body fat percentage, and there is ectopic fat deposition, there is deep subcutaneous fat deposition, there is overflowing of fat in the subcutaneous tissue, in the visceral fat areas, and the organs which are not tuned to contain fat beyond 5% of their weight, they start taking care of the fat. And that begins right from the womb of our patient mother. So that is very important integral part of thinking now. So there are a lot of complexity of diet and multiple influences, they affect the food intake. There can be individual factor like age, gender, and also the ethnicity of the person, biology and genetics and epigenetics and metabolic phenomena. Then various personal behaviors, consumption of substances, movement, actions, sedentarism, social economic factors, community and environment, food environment, availability and access to the food, agriculture and industry market forces which are driving everywhere. There is cola culture, there is McDonald's, there is Swiggy, you can say there is Blinkit and everything. They are so fast. They are giving 24/4, 24/7, the food which is laden with a lot of calorie, but nutrition deprived food right on your doorbell, right at the time of your giving any call to them. Within few minutes, they will bring you around the clock. So there are global changes which are happening. Also, there are trends and demands from the government also, from planetary sustainability also, organic food production also. All these things lead to a lot of changes. And there is, again, an extremely complex phenomena to prescribe a diet, and that should be sustainable for a person who is sitting in front of you. So what is the best eating plan for people with diabetes and pre-diabetes? Very, very simple. As per the guidelines, if you go through the guideline, we must accept the guidelines. They advise different variety of style. It can be Mediterranean, it can be vegan, vegetarian, low fat, fat ornish, low carb, very low carb. And I think it's a mind-boggling things which comes in front of you and what to prescribe and how long to be prescribed. A person who is a layman, who is a villager sitting in front of you. Can we go to intermittent fasting? A new generation guy will come in front of you and intermittent fasting, keto diet, paleo diet. I think there are more than 200 types of diets which are available on the net. So most of us, we follow definition of carbohydrate focused diet or calorie restricted diet. So if you go to carb restricted diet, there can be various type of classification. Very low carb diet, that is keto diet, less than 10% calorie coming from carbohydrate, but that is very poor to sustain. Definitely effective for short term, but very poor to sustain, very tough to sustain because most of the calories, 90% should come from fats and proteins. And it's very tough to have that type of diet in routine practice for long term. Low carb diet, very well accepted. 10 to 26% calorie from carb. Moderate restriction, 26 to 45%. So I personally feel this type of diet of having carbohydrates of 26 to 45% is good enough. That means you will be balancing around 150 grams of carbs per day. And you can divide between various types of, you can have lunch, breakfast and dinner, dividing more in the breakfast, somewhat more in the lunch, but lesser in the dinner part. So you can have a different permutation of or division of 150 gram. You can divide very nicely. So that makes around 26 to 45% of total carb, but that carb quantity has been decided, but the quality should be also decided. That is very important. Otherwise, you will land up in trouble. So you can have low or very low carb diet and low and very low calorie diet. So where is the difference? If you see the data tells you that low carb diet improves cardiovascular risk for up to 2 years, not beyond that. Whereas low calorie diet improves your curiosity score for 2 years, not beyond that. So what about that? Beyond that, what will happen? Here, both of these two diets lead to some amount of weight loss, but more important when you are going with a low calorie diet. Low calorie diet definitely leads to body weight loss, 10 gram in active arm for 12 months. It was there in direct study, which we all follow. Droplet study also showed there is 7.6 kg decrease in 2 years with the direct study. All these things, these trials are very emphatic for low calorie diet. Mean weight loss was around 13.7 kg at 6 months. So definitely it is much more important in comparison to restricting only carbohydrates. So it's a very important to understand. Low calorie diet, giving you the calories, taking calorie around 850 to 1000, that is more enough. And that gives you benefit of decrease in body weight up to the tune of roughly around 14 kg around within 6 months. What will you get? You will get remission of diabetes in 46% of patients at one year. So 12 months. And these patients will be out of the roughly around 36% will be continuing in remission for 24 months. So at least 2 years, you will find 36% patients are in remission. And your liver fat gone, your pancreatic fat gone, your muscle fat gone, your ectopic fat gone, everything in very healthy tune. Everything will be in very, very healthy tune. With low carbohydrate diet, you have got one trial, that is the look ahead trial, that showed the difference, decrease in 11% decrease in those patients who are having active lifestyle along with exercise and program and low carb diet for 1 year. So 11% they went into remission. But further down the lane, what happened? We don't have any follow-up of that. But ultimately, if you see the direct trial, that clearly indicated that memory effect, metabolic memory effect, still persists up to 36% patients for 24 months. So that means it's a better deal to go with a low calorie diet in comparison to purely low or very low carbohydrate diet. Now, there is eating plan to manage pre-diabetes and reduce risk of type 2 diabetes. Most robust research is Mediterranean style. I definitely, myself, I try to go with a Mediterranean style, but only thing, there is red wine that is there is more of fishes that is there is olive oil that is there. But ultimately, if you follow the routine diet of Indian scenario, the grains, the vegetables, the fruits, there is or granular grains, more fiber diet, that is definitely they are following a sort of Mediterranean diet. There is Predimed trial, which is very recent trial that compared med style with a low fat, found 30% lower relative risk with med style in comparison to low fat diet. And epidemiological studies correlate med style, vegetarian, DASH eating pattern with low risk with no effect for low carb diet. So low fat diet, I think that we should not follow. Low carb diet, not to be followed. Low calorie diet, that is good enough. And that should be nutritionally complete diet. So this is the basic pattern, the pyramid that should be there on all our tables. We should tell patient which are the choices for the grains, breads, and all starches, and all these should be coarse, chewable, more chewable, less refined, less polished. More vegetables, more colored the plates you should have. Fruits, try to be raw fruits, properly washed and raw fruits. Some amount of milk and good amount of protein that is required. Both vegetarian protein and if you are able to take non-vegetarian protein, the answers are in front of you. Fats and oils are essential, and that should be taken in a stipulated amount. And again, this is the pyramids which everybody can see and everybody can follow very nicely. So there should be 2 or 3 serving of non-starchy vegetables which are essential. And don't try to give them 5 or 7 serving. No problem. No issue. Nobody can afford 2 servings of fruits, good enough. Nobody can afford 6 servings of grains, beans, and starchy vegetables, good enough. 2 servings of low-fat and fat-free milk, good enough. About 6 ounces of meat or meat substitutes you can take, and small amount of fat and sugar is also allowed. So this is the simple meal pattern or the basic plate method, but the size of plate should not be more than 9 inch. Half of that should be totally colored with the cooked and raw vegetables and salad and fruits. Remaining half should be divided into 2 parts. One is your carb part, that should be bread, starch and grains, but they are all should be granular, multigrain, or you should be more consuming millets. And millets should not be polished. So no polished millets, all those are accessible, those are available, because you can see the Haryana, Punjab, from where I come, it's a bajra, jowar, rye. They are all well nicely available, and they can be blended with small amount of your wheat, and that should containing bran also. Some brown rice you can consume, and that is all that is required. Some proteins in the form of good amount of dal, in the form of nuts, and also in the form of milk products. They should be taken. Otherwise, they can be taken with the non-vegetarian. Fruits allowed, and small amount of milk, and 1 cup or half cup of milk, yogurt. Definitely that is required. So percentage daily values based on daily value recommendation. If you have a 2000 calorie diet, you must see these are the patterns we must follow, but these are too complicated. I don't feel that these are the things which can be told to your patients. They are just for all of us to know, but not to be replicated with the patient. Patient should know what should be there on their plate. That is most important. These are the things which are available as per the guidelines and as per the measurements, as per the recommendation. You can have them, but that they are only guidelines. The bottom line is that evidence does not support a clear preference for a specific eating pattern. The thing that patient should enjoy, it should be scientific, it should be healthy, it should be realistic, it should be easy to be cooked and easy to be achieved, it should be sustainable, which is very important, and it should be tasty. Why to lose the taste of the food? And it should be healthy. So that's what I call a Shresth diet. That is important. So in type 2 diabetic patient, for individuals that are overweight and obese, at least 5 to 10% of weight loss is recommended. And that you can get, you restrict the calories, make it a deficit of 500 calories every day. Along with that, 250 to 300 calories by exercise, you can make a difference of around 600 to 700 calories, and that is good enough. But if you do like this, you will be definitely going to lose body weight by around half a kg per week, and within 1 month, around 1.5 or 2 kg per week, per month, and that is good enough way of losing body weight along with maintaining the muscle mass. So don't go into sarcopenia. That is important. So goal for optimal outcome should be 15%. We all know it, but it has to be slow. It has to be slow. 6 month, 1 year journey, and you have to persist with that weight loss. That is the way to treat overweight and obesity, and to bring down the type 2 diabetes drugs and to make it into remission. So in pre-diabetes, the goal is 7 to 10% for weight loss for preventing progression to type 2 diabetes, and in patient with type 2 diabetes from pre-diabetes, and we should be very, very aggressive in these type of patients, and we don't want to get them converted into type 2 diabetes, because if you see the data of ICMR, it is roughly around, say, 150, around 15 crore people are having pre-diabetes, and roughly around 112 crore people are having diabetes. And if you go into overweight and obesity, overweight is roughly around 351 million and overweight is around 250 million. And out of these, if you take pre-diabetes, we are just under diagnosing pre-diabetes. We are just not looking at pre-diabetes. and that is the area we must focus to prevent their conversion from pre-diabetes to diabetes. In type 1 diabetes, there is a pure game of carbohydrates. It should be carbohydrate counting that is important. But recently and of late, we are seeing overweight is a big issue coming in type 1 diabetic patients also. So weight management is also an integral part of management of type 1 diabetes. Here is a frame of reference, 7% or 15% body weight loss. If you have got this type of current body weight, you can lose like this, but it should be very realistic. It should be achievable goal, and it should be healthy weight loss. Even you can overshoot by using those drugs like GLP-1 and GIP-GLP-1 combination. We have seen patients going into sarcopenia. That is not an appropriate weight loss. That is not appropriate. Even numerically, you will be achieving 20% body weight loss, but that is not required. That is not healthy weight loss. So additional weight loss and maintenance is the key takeaway. Focusing on moderating portion size, reduce energy intake, simple. Aiming for a collaborative efforts between healthcare providers with people with diabetes and to reduce body weight. So it should be HCP driven policies, it should be HCP given protocols, it should be nutrition expert and dietitian who is totally qualified in prescribing diet and weight loss management. That should be at your back. So that is important message. Combining weight loss programs with more physical activity is a key factor for maintaining and sustaining weight loss and also for maintaining your muscle mass. These are the consensus guidelines for healthy living and prevention of obesity in metabolic syndrome. This is from India. Professor Anup Mishra was the key driver for that, and he has given this guidelines, and very clearly whatever I have enumerated, that is clearly alluded here, and that is the way. If you want to exactly know how much figure you should take about the fats, carbohydrates, saturated fats, and also percentage of fibers, both soluble and insoluble fiber, how much servings you can take. This is the best article you can see, but it is 2009 guidelines, and we want that it should be more amended. You have got recently 2021 ESC guidelines on cardiovascular disease prevention in clinical practice, also giving you nearly similar factors, nearly similar way of recommendations like class 1 and class 1A recommendation for low calorie diet, high fiber diet, and also for maintaining weight loss and losing body weight, more vegetables, more fibers, restriction of some amount of saturated fats, more MUFA and PUFA. All these are important things. And we have got just recently standard of care 2024 guidelines also recommending nearly same things as I have just alluded to you. I think it's more important to look at the plate of the patient, tastes of the patient, also religion and socio-economic status of the patient, pocket of the patient, what are their liking, that is more important, and then just change few things, and don't try to change whole concept. Don't try to change the whole government just like Nepal. We must change few things here and there, just like a chessboard working, and see the results that are happening, because that is the most important way to change a patient's behavior towards feeding. It's more of behavior, it's more of taste fiber, it's more of liking, and it requires some time to sit with the patient, not giving handout to the patient in the form of dietary advice. So the holy grail of modern medicine is you can't fix healthcare until you fix health. And you can't fix health until you fix the food. And everyone among us is talking about healthcare. And very few people are talking about health, and nobody is talking about food. If you see the whole conference, dietary advice and nutrition, they are on separate hall. Separate hall. If you wish, you can attend, but that is not mandatory. I think we must make it mandatory for all of us to sit there and listen to our dietary colleagues, nutrition experts, for how to prescribe diet to our patient who is sitting in front of us. Thank you.